Welcome everybody to this MDS roundtable. My name is Guillermo Garcia-Manero from the Department of Leukemia at the University of Texas MD Anderson Cancer Center, and I'm very pleased to be here today in this teleconference. Now, we have seen a lot of progress in drug development, but also actually how we understand this disease. And Solly was talking about the IPSS-R and the IPSS-M, but let me ask Jamie if she can give us kind of like an update on first of all, actually, how do you do that at Hackensack? How do you stratify your patients? Do you do both? Do you use one? And some pros and cons, or kind of a view as an expert in terms of how do we use these kind of prognostic models that are so important, in my opinion.
Yeah, absolutely. So at least my personal practice has really been to calculate both risk scores. So the IPSS-M, of course, incorporates molecular data into our risk stratification and actually adds another sort of level of risk stratification, or gives us another category of risk. As compared to the IPSS-R, so certainly I am calculating it both scores for my patients. I think it's particularly important in transplant eligible individuals. There was some data, and we discussed this, I think, that was presented at ASH over the past year that showed that the IPSS-M is really a better prognostic model. It helps to more accurately identify patients who would benefit from earlier allogeneic stem cell transplants. So I think particularly for that group of patients, it is really important to incorporate that molecular data and use the IPSS-M. However, I would also argue that when we're deciding about a supportive approach with an agent like luspatercept or epoetin alpha or another ESA versus more disease-modifying therapy with a hypomethylator, that even in a transplant ineligible patient, really risk stratifying that individual to the best of our abilities, ultimately we hope is going to help us bring the right treatment to the right patient. So certainly, I'm calculating both risk scores. I have my own sense, I think, right? You have those, IPSS-R intermediate risk patients, which sometimes could go either way. Again, I think that group of patients, as we look at some of the molecular attributes of their disease and calculate their IPSS-M, can really help us in terms of, making a treatment decision going forward. Not to say that there aren't other patient-specific factors like comorbidities and goals and quality of life that I integrate into my decision-making. But certainly, I think the IPSS-M gives us more information, gives us more accurate information, and that's certainly the direction that I think the field is moving in.
That's a great answer. So I do the same as you do. I calculate both. I think one thing that I don't have an answer, but I think one of the things that is happening is this phenomenon that sometimes we see where you have a patient with like low risk features, like let's say low percentage of blasts, maybe the chromosomes are not that abnormal, maybe the cytopenia is not that severe, a little bit of anemia. Actually, this week I saw like 3 or 4 new patients like this. But then all of a sudden, you run your NGS assay, and this person has a significant P53 mutation or 4 or 5 mutations. And then all of a sudden, when you compare the IPSS-R with the IPSS-M, the risk goes up. This, from clinical trial perspective, these are kind of difficult because the IPSS-M has not really yet been incorporated into clinical trial design. So we're not saying you're like higher risk by IPSS-M, low risk by IPSS-R, and we're not there yet. So, Solly, you were saying referral to, centers, etc. But how do you react to that actually in your practice? All of a sudden you have someone who quote unquote has kind of benign features, and then I guess a couple of weeks later or whenever time it takes for you to get the NGS test, you say, wait a minute, you now by IPSS-M has moderate high disease or a really concerning mutation. That actually to me is something that I'm seeing quite a bit now, and I find it very interesting. Is not the proper word because it's kind of difficult for the patient, perplexing, like difficult. So how do you react to this?
Well, I mean, especially I feel like we're diagnosing MDS in younger patients all the time. Getting next-gen testing is substantially easier, and we're doing it for everybody at this point now with with new onset diagnosis. So I think that we're diagnosing these much earlier, and essentially, I'm referring these patients to our local transplanter, so or transplant center. So I think it's important. That's the only curative modality that we have at this point, and the IPSS-M, from my understanding there was also that I think there was about 5,000 patients who were the sort of real world data that was being assessed as well. So hopefully that's being kind of validated and kind of there's more data being applied towards that. But I think it's reasonable, especially in young healthy folks, that they be at least have a discussion that you've got some high risk features. And even though sort of an older model doesn't appear to be as that you would be as in as bad a shape, that potentially this disease could be substantially worse than it initially appears. And I think it's reasonable to at least have a discussion and have the person be in touch with a local transplant center so that could be on their radar. And so you're not just scrambling trying to get them evaluated when things if and when things get a little bit more worse.
I'm interested actually to hear from Tom. What is his perspective on the new agents? How are you taking this, for instance, at Duke, the incorporation of luspatercept? What is your vision on imetelstat and maybe the oral HMAs if you have time?
What you were just talking about with the IPSS-M really rings true for me. For example, I've been struggling a lot with this idea. If I see a patient who has lower risk disease by the IPSS-R, but then and doesn't have a high blast count, where I'm thinking, they really don't probably need or benefit from disease modifying therapy initially. Those are the people we've always gone with supportive care approaches for. And when we only had ESAs and transfusions, we've all had patients like that who go for 3, 4, 5+ years getting supportive care and have good quality of life and don't progress to leukemia and they do well. You don't want to sentence that person to 4 to 6 months of an HMA where they're going to get worse. They might require transfusions, their counts drop, they may be in and out of the hospital with infections and complications, and then the response rate isn't even that great to a single agent HMA. So, I've still tended to think if somebody's lower risk and it's behaving that way clinically, I'm erring much more on the side of using all of the supportive care therapies that we have available now, and there's more of them, which is great, and reserving the more disease-modifying therapies for the patients who clearly have high blast counts, who clearly have very high-risk disease, who benefit from transplant, who need to go to transplant, where we're trying to achieve disease control, delay or reduce leukemic transformation, and get them to hopefully a curative allo. And it's those ones in between that you described that I think are the hardest, where somebody doesn't have a lot of blasts and their counts aren't that bad and they're feeling okay, but the IPSS-M tells me this is going to go badly. I still don't, we don't have the data that says you should give those folks HMAs, for example. So it's the classic story of prognostic models being useful to predict what happens to a population of patients, and they can be really good at that. But that's in 100 people. What's going to happen to the person sitting across from you in the exam room? It never really tells you that. It just gives you a sense for which way to hedge your bets. So I do use a lot of the supportive care therapies, and I think that with the COMMANDS trial, it's pretty clear to me that using luspatercept as a first-line therapy, really for most of these kinds of patients, is probably just our new standard of care. I have been a little bit frustrated, actually, that there's been so much debate about the EPO greater than 500 in the serum patients. And I'm always trying to tell people, you could not ethically do the COMMANDS trial if you randomize people with an EPO level of over 500 to get EPO when it's not going to work. That's the only reason why those patients were not on the trial. It has nothing to do with luspatercept not working in people with a high EPO level. So the discussion that if your EPO is over 500, maybe you should get imetelstat. I don't believe that. And I know that when we prognosticate, if somebody has lower risk MDS and they're expected to live 5 or 8+ years on median, we need every option we have. So I want to use the best one first, which to me is usually going to be luspatercept. R is positive, negative, whatever. Even if it works about the same for transfusion independence in RS negative, it still looks to me like the duration is longer. And I also think that if you use it after EPO, it doesn't work nearly as well or for as long. So, for me, I keep it simple. It's the better drug. I think it probably works better for everybody in general. I'll use that first, and then I'm going to save the next bullet that we need against this disease, the imetelstat, for the next line of therapy for a lot of these folks. Of course, it gets more complicated than that with each patient, but like generally speaking, that's the way I've been thinking about it and approaching it.